Hello, everyone. Hi, my name is Lena Capovir, and I'm the program manager for the treatment division. I do apologize for the brief delay. We were having some technical difficulties, but here we are, and we are very excited to be sharing something that's really important for our communities, our constituents, especially those who are living and aging with HIV. And today we are going to have a CROI community recap, recent data on HIV aging, and why this is important is because for the first time in history, and thanks to advances in medicine, there is a large number of people aging with HIV in the US. And in fact, the CDC estimates that the number of people living with HIV who are 65 plus nearly doubled from 2013 to 2017. And also recent data shows that more than one third of those who are aging and under HIV treatment will suffer from multiple comorbidities by 2030. So to discuss all the important information that was shared during CROI, today we have David Hardy, Dr. David Hardy, who is a scientific and medical consultant focusing on developing novel vaccine and cure remission strategies for human viral diseases. He currently serves as adjunct clinical professor of medicine at the Kick School of Medicine of USC and previously served as professor at Johns Hopkins University School of Medicine. He has served as editor-in-chief of a clinical textbook, Fundamentals of HIV Medicine for the HIV Specialist, with the most recent version published this year. He served as Senior Director of Research at Whitman Walker and previously as Director of the Division of Infectious Diseases at Cedars-Sinai Medical Center and Professor of Medicine at the David Geffen School of Medicine at UCLA. David Hardy has cared for people living with HIV since the beginning of the epidemic and has conducted research on HIV and related diseases since 1984. His research has focused on treatment and prevention of opportunistic infection, anti-retroviral therapy, immunotherapies, and many other topics around HIV. So I'm going to let David Hardy so we can jump in. And for those who have questions, you can put it on the chat box and we will address them at the end after the David Hardy's presentation. So thank you, David, for joining us, and it's all yours.
Thank you very much, Damien, for that very kind invitation and kind introduction. This is something that I really enjoy doing. I have been working with INMAC for several years. When I lived in DC for 4 years, I had the opportunity to get to interact with INMAC very often, especially with this group of persons living with HIV infection who are over 50. And this is, I think, about the third or fourth time that I've gotten to present information to you guys and others, I'm sure. Today, we're going to talk about CROI, or the 2021 Virtual CROI Conference. And why is CROI important? CROI, which is an acronym that stands for Conference on Retroviruses and Opportunistic Infections, has been going on since 1993, and it's probably the most important research conference in the world of HIV infection and treatment since the beginning of its time. And it's a small conference, it's a very focused conference, and it's usually the place where big information about new advances in HIV treatment are broken. So I will start off and just go through my slides to if I can get them to work. There we go. Here's my name, David Hardy, and as Damien already mentioned, my disclosures are on here as well. We're going to go over 6 different topic areas today that the conference was all about. I'm going to try to cover the ones that are most relevant, kind of most important, I hope to the group of you guys listening today, and I'll leave time for questions at the end. About half this conference was about COVID-19, either with HIV infection or by itself. And so I'm going to hit some of the highlights about what this was all about. One of the things that was a very important part of the conference was looking at the COVID-19 vaccines. And one of the studies presented there was a evaluation of whether or not someone who had COVID and got the vaccine, how they did with the vaccine in terms of their immune response versus persons who had never had COVID-19 and got the vaccine. So there were 13 people in this small study who had had COVID before and got vaccinated with either the Pfizer or the Moderna vaccine, and 20 people who had not had COVID. Small study. And what they did is that after each dose, first dose and second dose of each of these vaccines, they drew blood to see whether or not what kind of response they were having. They did two very important blood tests on those blood samples. One was a simple what's called antibody test against the spike protein. The spike protein is the part of the SARS-CoV-2 virus that we want to develop immunity against, protection. And the other kind of test was what's called a live virus microneutralization assay, which is a laboratory test in which they can test whether or not the person's blood and the antibodies in it actually neutralize, or for lack of a better word, kill the virus. And so they wanted to check for the type of antibody and whether the antibody would work against the virus. What they found was rather interesting. After a single dose of the mRNA vaccine in persons who already had COVID disease before, they found that these antibodies were as high as the persons who had got two injections of the vaccine, but had never had COVID before. So the other thing is that the levels of the antibodies were not boosted in the persons who already had COVID by the second dose, but they were in the people who had never had COVID after they got the second dose. There were higher neutralizing or antibody killing titers or levels and against new variants than the naive people, and the binding of the antibodies in the persons who already had COVID before did not increase much after the second dose. So basically what it was telling us is that in persons who already had COVID and who are all recommended to get the vaccine, that they seem to have about the same response after one dose than the persons who had never had COVID had after they got two doses. The important thing I think I want to point out here also was that they found that there were higher neutralizing antibody titers against new variants. So the persons who had had infection before and then got a dose of vaccine seem to have broader immunity than persons who got two doses of the vaccine. This sometimes happens because natural infection oftentimes produces broader types of immune protection than a single dose or even a double dose of a vaccine. The study was small and it was not including all kind of risk groups, but at least gave us some idea about what having COVID before does. Now I'm going to hit a couple of treatment studies just to give you a flavor of the fact that there has been some rapid development of some very important treatments for people who have mild COVID and those who have recently been exposed to COVID. So there was a study called the BLAZE-1 study, a COVID-19 treatment study done with two what's called monoclonal antibodies. These are proteins that are genetically engineered to work very well against the COVID virus. You might remember hearing about what's called BNAbs, or broadly neutralizing antibodies, that we have been using for HIV for many years, and they are also being used for treatment of HIV, monoclonal antibodies. The same kind of technology is being used in COVID. What we've learned, for example, in HIV is that it takes two antibodies to work well, and so they did this. They actually started off in treating COVID with two antibodies. Their names are kind of long and funny: bamlanivimab and etesivimab. And they gave these to individuals, to people who had early signs of COVID, mild to moderate COVID disease, and they gave it both to persons who had no co-risk factors for getting sick, and they looked at what effect giving the antibody versus giving a placebo had on someone who had very early COVID disease. What they found, and as this graph shows to the right, the higher the graph goes up, the higher the chances the person got hospitalized or had any cause of death, whether it was COVID related or not, it was counted. What they found was that there was a 70% reduction in the chance of a person getting hospitalized or having any death problem if they got the antibody versus if they got the placebo. Much like what we have seen with anti-HIV monoclonal antibodies, these antibodies against COVID also decrease the viral load. They made the symptoms of COVID disease go away faster, and there were no deaths associated with getting the antibody versus 10 in those persons who got placebo. So this is actually a nice transfer, I should say, of HIV treatments that have been used to try to treat HIV infection, but transferred to another viral disease, in this case, COVID-19. They also gave a different monoclonal antibody combination called casirivimab and imdevimab as a subcutaneous, just under the skin injection in persons who had been exposed to COVID from someone else in their house, in a household contact. So they randomized people who were in a home and who had got exposed to someone within the previous 4 days. That person had to have a positive COVID test from their nose. And if that was true, then the persons who were in the same household but weren't actually sick at the time or even had COVID at the time were randomized to receive these two antibodies or a placebo. And again, what the results were pretty dramatic. In the persons who got the antibodies versus those who got the placebo, there was no symptomatic COVID disease. There was no high virus positive COVID test from the nose at all. And there was a remarkable decrease in any positive infection, any COVID positive infection. So these antibodies, again, protected people who were exposed from actually getting COVID disease. This would kind of be thought of as what we would call post-exposure prophylaxis, or PEP, for COVID. You know, we've used PEP in HIV for a long time when someone may have been exposed, both healthcare workers who get stuck with a needle or a scalpel, or persons in the community who may have had a sexual encounter or a drug use encounter with someone who was positive, and they find out perhaps after the fact and want to try to do something, and they can take what's called PEP, or post-exposure prophylaxis. This is the same principle, except it's being used for persons who got exposed for COVID, and it worked. So in addition to remdesivir, which many of you probably have heard about, and I'll just say from the outset, remdesivir, came on the market, came onto the scene, I should say, very fast because it was already being evaluated for other kind of viral infections, some of which it had worked for and other which it hadn't. And it was found to have some modest effect, although there's still questions about how good remdesivir is. Well, by the time COVID was really going crazy, another medication, an antiviral medication called molnupiravir, was being developed as well in non-hospitalized people. So in a smallish size, 200 patient phase 2 study, they found that persons who had fever or symptoms of COVID within the previous 7 days and had a positive COVID test from their nose were randomized to receive a placebo or receive molnupiravir. They got either 200 milligrams or 400 or 800 milligrams over 5 days, each day for 5 days in a row, I should say. What they found after day 5 was that there was no infectious virus in the persons who got the molnupiravir on that day. And so what this is telling us is that the molnupiravir is eradicating or suppressing the production of COVID virus very, very well in persons' nose. A larger phase 3 study is now ongoing to see if this can actually be translated from simply eradicating the virus to actually trying to treat or prevent the disease. And we'll hear more about molnupiravir in the future. Now, one of the big questions has been about the overlap of persons who have both HIV and COVID-19 at the same time. And so many different retrospective, looking back, cohort studies have evaluated whether or not persons who are HIV positive have an increased risk of either getting COVID or getting sick with COVID, if they do get it. And so this was a look back at almost 300,000 people over the entire year of 2020. About 0.6% of that 300,000 were HIV positive persons, so not a whole lot. But just to put this into context, 0.6% is about the average percentage across the United States of persons who are HIV positive. Of course, that's very different depending upon where one lives, whether one is in an urban or rural area, but 0.6% is about where we stand as far as number of persons who are HIV positive in the entire country. Basically, what they showed was that persons who were with HIV and who had COVID were more likely to be male, African American or Black, obese, and have concurrent cardiovascular disease, but no HIV, or versus HIV negative people. What they also found was that the good news is that there was no difference in mortality within 30 days, which means that persons who are HIV positive were not dying any faster from COVID than those who are HIV negative who got COVID. They also found that, however, that there was a higher rate of hospitalization, of having to go to the hospital for medical care, of going into an ICU, and also being put on a ventilator. So while persons didn't die of COVID who were HIV positive more often than persons who are HIV negative, they were perhaps had a little more severe disease because they had to go into the hospital, be in the ICU, and get a breathing machine hooked up to them. So I think one of the things that's really important here that really emphasizes what the risk factor for HIV and COVID may be is it's not the HIV so much. And in fact, that's what this study from Atlanta showed. Both a Ryan White Community Clinic and a VA Medical Center clinic got together and enrolled about 180 HIV positive persons between March and November of last year. And what they found was what the primary driver of whether or not someone got hospitalized because of COVID was really dependent upon how many comorbidities they had. And as you see in the table to the right, as the number of comorbidities increases from 1 up to 5 and greater, you can see what's called the odds ratio of someone getting hospitalized. The greater the number of the odds ratio, the greater the chances that person's going to be hospitalized. And so you can see there's a very clear correlation between the number of comorbidities and the chances of getting hospitalized because of COVID. What they found in here also was that there was no association with HIV parameters, meaning that there was no association with viral load or CD4 cell count as far as an HIV positive person being hospitalized. It was all about their comorbidity numbers. And so this is something that we actually already know is occurring in persons who are HIV negative. So the difference here is really not significant from this study, was to show that it's the comorbidities, not the HIV, that really determines whether someone goes into the hospital HIV positive or not. And the last study I'll talk about with COVID is one from Spain, and it was a study that was kind of unique for 2 reasons. Number one, they took about 1,000 of their patients and they checked their blood for anti-COVID antibodies to see whether or not they'd been exposed to or had COVID. What they found among their HIV positive persons is about 9% had detectable anti-COVID antibodies or evidence of having had it. They did a correlation with severity of the disease. They found that 45%, almost half, had no symptoms. They were asymptomatic. 51% had mild to moderate, and only 4% had severe. Very much in line with the numbers for persons who are HIV negative. The thing they found to be associated with having COVID was actually birth in a Latin American country. And remember, this is done in Spain. So this is evaluating, this is showing that people who are from Latin America, compared to those who are in Spain, had a higher rate of getting COVID. And that higher rate was about 2.43 times. Whether or not they had and also if they had high blood pressure, or if they were receiving a medication that did not contain tenofovir FTC or Truvada. This is one of the few studies, although it's an important one, that showed that Truvada may have a protective effect against getting COVID. However, there have not been really any other studies that have shown that. So I would not hang my hat on having Truvada protect someone from getting COVID. But the thing interesting here was that people from Latin America were more common to get COVID than persons from Europe. Let's move on to HIV prevention, because there were some really interesting studies here as well. You probably all have heard about the ANRS, the French ACTG study called the Prevnier Study. which was a study that compared two different strategies for using PrEP, either daily tenofovir FTC or daily Truvada, or what's called on-demand Truvada, in which someone takes 2 tablets of Truvada just before they have sex, anywhere between 2 to 24 hours before sex. If they do in fact have sex, then they take a 3rd dose 24 hours after the sexual encounter, and then a 4th dose, 1 more pill, 48 hours. So it's a 2-1-1 sort of dosing regimen with on-demand PrEP. In this study, they had over 3,000 people involved, and it was not a randomized study, it was a chosen study. People got to choose whether or not they wanted to take daily PrEP or take on-demand PrEP. And so the bottom line from this study was actually very interesting. What it showed was, in fact, that the number of people who got new cases of HIV in this study were exactly the same, 3 in each arm. And this really showed a big reduction in the prevalence of HIV infection compared to persons who got a placebo in a previous study, or who were in the community and not on PrEP at all. So this was a really significant decrease by using either one of these strategies. They found, interestingly, that most people who were taking the medication either with daily PrEP or on-demand PrEP were taking the medication correctly, 97 to 98%. There was only a small number of people who were doing it incorrectly. There was very low condom use, anywhere between 18 to 20%, and a high rate of STDs. There were some adverse reactions that were associated with this, not great, but the most common ones were ones that occurred in the gastrointestinal tract, like nausea and some stomach upset, and rarely diarrhea. And so this was the thing that was, it showed that whether you took the Truvada daily or whether you took the Truvada on an on-demand basis, there was really no significant difference the way you took it in terms of the chances of getting a side effect, which was kind of interesting as well. And so finally, the take-home message from this is that at least among these MSM and transgender women, there were no cisgender women in this study, that taking the Truvada once a day or on demand were both highly effective. They were both well tolerated with very few discontinuations because of adverse events. Most of the people stayed in the study, which is usually a good sign that they're doing well. And there was a very high incidence of STDs in this study, as has been seen in many places around the world. Now, the other study I wanted to talk about is this one, called the HPTN 083 study. Now, this is a significantly important study because last summer at the International AIDS Conference, we heard that the results of this study were pretty dramatic. This study was comparing Truvada daily as a form of PrEP in men who have sex with men and transgender women who have sex with men versus our first injectable medication for PrEP called Victegravir, given once every 2 months, 1 injection once every 2 months. The way this study worked is that everyone took oral medication at first, either oral Truvada and then oral Victegravir. It was blinded, so they didn't know which one they were taking. And then after 5 weeks, then the persons who were taking the oral Victegravir were switched over to injectable Victegravir, and they continued an oral pill at the same time. And the people who were on the Truvada and a placebo continued to take the Truvada, and they got a placebo injection that was just like the Victegravir injection, and they've been followed on for a while. So the big news from this study was that at an early time point in the study, they found that there was a great imbalance between the number of new infections between the two treatment arms, or I should say prevention arms. 39 new HIV infections were occurring in the Truvada arm, 12 in the injectable Victegravir arm, which really was a big difference. And as that little graph there shows on the right, called the hazard ratio, we see that not only did this comparison meet what's called non-inferiority or similarity between these two strategies for prophylaxis, for PrEP, but it also reached what's called superiority, which meant that that the cabotegravir was in fact superior or better than the daily oral Truvada. Now, one of the big questions that we learned about and hopefully got some answers about at CROI was looking at a patient by patient analysis of, I should say, study participant by study participant analysis of how they became HIV positive. So of the 12 positive, new positive infections with HIV, the first 4 there, A1 through A4, occurred before the persons even came in the study. They somehow slipped through the screening because they were already HIV positive before the study started. The next 5, B1 through B5, were positive because of the fact they stopped being participants in the study. And there was a long period of time in between when they got their last cabotegravir injection and when they became positive. The third group, C, were individuals that became positive during the oral lead-in phase. Before they ever got any injections, they were found to be positive. And so those 8 infections were pretty easy to explain why they occurred. They were not prophylaxis or cabotegravir failure. But what they did find was that there were 4 cases, D1 through D4, in which it was documented that the persons got all of their cabotegravir injections as they should have, yet they still became positive. And the question became, how did this happen? How did it fail in these 4 people? What they found in this situation was very interesting, and that was the fact that they found that in retrospect that the way they could have detected new HIV infection was not by the antibody test, because there was a delay in the antibody test becoming positive. And had they been using the HIV viral load test, the HIV RNA test, they would have picked it up earlier, because the antibody test was not being able to pick it up quickly enough in order to stop the medication. So what it's telling us here is that even though these persons got all their cabotegravir injections and had high levels documented in their blood, some people, 4 out of over 2,500, became HIV positive despite the injections. More is going to have to be learned about how that happened, but we do know that the best way from this study tells us is that the best way to detect HIV infection is not the antibody test or even the antibody antigen test, but the viral load test. The other thing we learned in here is that 7 of the 16 people who in the cabotegravir arm were found to have new integrase mutations, which was something that was unique to this particular integrase inhibitor compared to our other second generation integrase inhibitors like dolutegravir or Victegravir. So this has been a consistent theme. We know that cabotegravir is probably not quite as potent. It does do a good job at preventing HIV infection, better than Truvada, in fact. And it's something that we really, I think, can probably utilize more in the future. In the Truvada arm of the 39 new infections, what we know is that these occurred primarily because of lack of adherence. 37 of 39 were because of non-adherence. So that's really something that I think tells us that it's the same kind of thing we've always dealt with before. The take-home message here really is the fact that detection of the HIV infection using standard testing algorithms, standard HIV testing protocols, did not pick up the new HIV infections in the cabotegravir arm, but the HIV RNA did. What they found in some cases is that the initially positive antibody and the initially positive HIV-1 viral load test reverted to negative or non-reactive in some cases. So what this is telling us is that there was maybe some evidence that there was some early infection and seroconversion that did not actually proceed. And with the cabotegravir sort of as early treatment already on board, it prevented that. Looking down the road as to what's coming next in terms of other opportunities for prevention is that we're going to see more and more longer and longer intervals between the dosing for PrEP medications. One of those medications is called Islatrovir. This is a medication being developed by Merck, one of the long-term pharmaceutical companies in the HIV arena, and they're developing a drug called Islatrovir that has a very long half-life, or what I kind of like to call hang time in terms of being in someone's blood. They did a monkey study and then simulated that for a human study, and found that if they gave 60 milligrams, a 60 milligram tablet of Islatrovir, they can do that just once a month as an single oral pill to produce enough levels of Islatrovir in the blood and blood cells to keep someone protected from HIV. They showed that they could have protection against the monkey virus in a monkey model, and now they're extrapolating this to humans. And so there will be studies very soon that are using Islatrovir as a 60 milligram once a month study in order to show that this drug can be given on an oral monthly basis to prevent HIV infection. And why might that be important? Well, probably because not everyone feels comfortable getting injections. And so if someone wants to prevent PrEP but doesn't want to take a pill every day, this could be an answer of a once a month pill to prevent HIV infection. And taking this even a step further, this study actually looked at an implantable, what's called drug-eluting or drug-releasing implant in men and women who did not have HIV infection, but were at low risk as well. So this could be used as both a treatment or potentially as a prophylaxis. What they did is they put a 4 centimeter by 2 millimeters, 4 centimeters long, 2 millimeters wide little implant into the upper arm, just in the subcutaneous tissue just below the skin. This is the same method that is used to implant contraceptive medications in women, particularly in places where contraception is important, but pills aren't able to be taken so much every day. So this can actually last for as long as a year. They studied 3 different doses of the implant at 48, 52, and 56 milligrams of Islatrovir versus a placebo. And what they found here is that after 12 weeks, they saw that each dose of the medication worked pretty well at being able to produce levels that would be protective against HIV. They found that the best dose was the highest one at 56 milligrams in the implant, because everyone in the study had levels over that dotted line. The dotted line there across the bottom part of each one of those graphs, called the PK threshold of 0.05 picomoles per million cells, is the concentration thought to be necessary to prevent the acquisition of HIV infection. And so what we see there is that the dotted solid line shows the average for the whole group, but of the 8 people, there was a couple there in the red bars and the red lines that actually fell below that. And there was one, at least, or some in the green group that came very close. In the blue lines there, nobody got even close to that until they stopped the medication, or took out the implant, I should say, after 12 weeks. So this is, again, this kind of implant can be put in for as long as a year and be able to produce levels of medication that can prevent or perhaps even treat HIV infection once a year implant. And finally, the other thing coming down the pike is a capsid inhibitor called GSCA1, long-acting. It was studied in monkeys, and it was found that in the monkeys, the dose of either 150 milligrams or 300 milligrams per kilogram was able to protect the monkeys from infection up to a certain point. What they did is they really stressed this medication, because each week they gave a higher and higher dose of the monkey virus, the Shiv, to the monkeys until they actually caused the medication to break through. This was after a single subcutaneous injection of medication of this drug called GSCA1, one injection, and they followed out over 25 weeks. They found that the monkeys did not break through, even though the dose of the HIV, or I should say the monkey HIV, was getting higher and higher for about 15 weeks, which really shows that this drug has a lot of protection potential, and hopefully we'll see this kind of thing happen in the future as well. I'm going to hit a couple of important antiretroviral trials. The Atlas 2M study is the study that is going to, as many of you know, I should say, cabotegravir plus rilpivirine is now available as an injectable medication on a once-a-month basis of each of the two medications to treat HIV infection. It's been compared to an oral medication regimen and found to be just as good. The Atlas 2M study tries to push the limits on that from a dosing every 1 month to a dosing every 2 months. This study compared once-a-month dosing to twice-a-month dosing, and basically what it found was that even when the doses are increased a little bit, but stretched out over every 2 months, that the results are still just as good. The other thing I'll say about treatment is Victegravir, the medication called Victegravir, FTC, and TAF was compared to two different regimens containing dolutegravir, and the bottom line here was that in both of these studies, the efficacy of the dolutegravir versus the Victegravir were both very, very high and very, very efficient. 99 to 100% of participants had undetectability through 3 years, sometimes even as long as 4 years, out to 192 weeks. There was no resistance in either arms of the study. I'm sorry, there was one patient that had some resistance to the M184V, but no integrase resistance in either of the arms of the study. So again, this really shows what the durability of our two most commonly used integrase inhibitors, Victegravir or Biktarvy, and dolutegravir or Tivicay is really like. Side effects were minimal. I'm going to move on now to, I think, one of the more important parts about aging. Here's some information from what's called the NA Accord, the North America collection of many different cohort studies that showed that the projected burden of multi-morbidity among persons who are HIV positive. What this shows is in different age groups, less than 30, 30 to 40, 40 to 50, 50 to 60, 60 to 70, and over 70, that the number of physical comorbidities going from 0 in the green, 1 in the blue, and 2 or greater in the red is simply going to increase at a certain more increased rate over time. You see that that rate is the highest in the persons in the 50 to 60 and 60 to 70 and 70 and older group. So that over the next 10 years between 2020 through 2030, it is anticipated that as the number of persons living with HIV infection increases because people are not succumbing to the infection, and the projected number of people who are on ART in the United States is almost 1,928,000, that we would anticipate there's going to be more morbidities occurring, primarily because people are living longer. And there may be something to the fact that, of course, HIV infection itself, even when treated, may predispose to some chronic morbidities anyway. The MAX and the Ys are two long-term cohort studies that are studying HIV positive men versus HIV negative men, HIV positive women versus HIV negative women. And what this graph shows is that for the HIV positive men and women, the number of comorbidities increases at about the same rate and not different between the ages of 40 up to over 70. But interestingly, in those without HIV infection, it is showing that the women in the green dots there are developing comorbidities faster than men are. Kind of interesting. The HOPS cohort was trying to evaluate changes in weight, which is something that, of course, has been very, very timely in terms of what's happening with some of our HIV medications. So they evaluated 736 persons in their study who had changed their HIV medication over to an integrase or changed over to a TAF or did both. And basically the story of the study is in the graph there to the right. With the dotted green line, you see those that were on an integrase inhibitor, and then those who continued on that integrase inhibitor. In both groups, they increased initially in weight for the first few months, and then those who had changed their integrase and started TAF had more weight gain. But the ones who simply started who were on the integrase, their weight gains tended to kind of start to plateau out a bit, so it didn't continue. So it's the integrase at first, and then integrase plus TAF that seems to be the biggest factors for weight gain. Same thing for those persons who were not on an integrase. So those who were not on integrase and then switched to an integrase plus TAF had more weight gain than those who just switched by itself. So again, showing that it's the integrase, particularly dolutegravir, Victegravir, that are primarily responsible for this. I'm going to skip that one, go on to ART and pregnancy. I know this is something that may or may not be of great interest to people who are perhaps in their 50s, but it's important to point out two important things. Number one, for a long time, ever since it came out on the market, TAF has been a medication which has been not recommended for pregnant women because it was unknown whether or not it could cross the placenta and be able to protect the baby from the mother's HIV infection. This study actually showed that the effect of a TAF-containing regimen with dolutegravir was in fact just as effective and had actually fewer side effects, both for the mother and for the baby, than other medications. So it tells us that the viral load was actually lower in persons who were on TAF than who were on dolutegravir and tenofovir. I should say those who were on dolutegravir plus Descovy, which contains TAF, or dolutegravir plus Truvada, which contains tenofovir or efavirenz. Both of the dolutegravir arms in the kind of dark blue and the red there had a lower viral load percentage than those in the efavirenz arm. So again, this is telling us that there's another medication which pregnant women could take in order to treat not only their HIV infection, but prevent their babies from becoming positive as well. I'm going to just end this with a new medication, a story of a new medication that will probably be on the market. I'm going to guess sometime by the end of this year, early next year. This medication is called Lena Capovir, and it is given both as can be given as both an oral medication as well as a subcutaneous injection given every 6 months. The story of this study is one that we have seen happening more and more all the time. Sort of a quick and very efficient way for a pharmaceutical company to get their drug licensed is to study the medication in persons who have heavy treatment experience, those who have resistant virus, resistant HIV, and are very much in need of a new medication. The drug called Fostemsavir was approved by this mechanism. The drug called Ibalizumab or Trogarzo was approved by this mechanism as well. So it's a quick and small number of participant way to get a medication in front of the FDA for a question of approval very efficiently. So lenacapavir, which is in fact our first in-human HIV capsid inhibitor, and in fact it has activity against viruses that are resistant to the nucleosides, the non-nucleosides, the integrase inhibitors, and the PIs. So it has good activity, even though a virus may be resistant to 4 different classes of medications because it works in a whole new and different way. This study, again, a small, short one, took patients who had they were failing their current HIV regimen. Their viral load was over 400, even though they were on the medications. And they randomized people to actually add oral lenacapavir or add a placebo. They only did this for 2 weeks, and then they put everyone on lenacapavir on a subcutaneous basis. The dosing of this was 600 milligrams on the first day of the lenacapavir treatment, and then a third, 600 milligrams on day 1 and day 2, and then 300 milligrams on day 8. When they all went on to after 2 weeks, they all went on lenacapavir. They got a 1 subcutaneous injection of 927 milligrams, which would be repeated once every 6 months. So how well did lenacapavir work? Well, the FDA requires that in order to be considered to be an effective and potent anti-HIV medication, it has to drop the viral load by at least half a log. So what this tells us is that when we looked at the placebo on the red line there in the graph to the right versus the lenacapavir, we see that the lenacapavir by day 15 had dropped the viral load in the persons who started it almost by 2 logs, almost by over 200-fold. So that really shows some amazing potency. And so lenacapavir met and exceeded the target that it was asked to meet to show that it did in fact have good activity against drug-resistant HIV. If a drug has activity against drug-resistant HIV, it's very highly likely that it'll have activity against non-drug-resistant HIV as well. Of the 72 patients involved in the study, 2 did in fact of the viruses from these patients develop resistance. And so this is something that is important information for us to say that Lena Capovir is very potent. It's given, can be given by both an oral medication at first, and then as a once every 6 month subcutaneous injection that can be done at home. But there were 2 patients out of 72 that had resistance. So that's again something we're going to watch out for the future. The side effect profile with this was actually not too bad. Remember, these were individuals who had gone through lots of medications and were probably ones who had been treated for a long time. Is that whether they got the drug in a randomized fashion or a non-randomized fashion, they just got it right up front. Headache, nausea, cough, diarrhea were the most common things, but in small percentages of patients overall. And there were really no big side effect profile problems that were seen during this 24-week study. So we hope to look at more about this for the future. The other thing to look at with any kind of injectable medication, of course, are injection site reactions. There was some swelling, some redness, some nodule formation, and a little bit of pain, but it was actually in a minority of patients, 22% or less, and that was actually something that's probably a good thing. The nodules, however, did last a long time. So this is not exactly like the injection site reactions that we see with the cabotegravir and rilpivirine, which are short and go away. These last longer, but remember the injections are only once every 6 months. So I'm going to end there, and I left a little time for questions, but I'm certainly willing to hang on if you guys have more questions that we can answer. Thank you very much for your attention.
Thanks a lot, David, for that amazing presentation. Chip, do we have any questions from the audience?
We do have a few, so let me start in with those. In the study, is the SARS-CoV-2 experience people speaking to people living with HIV or non-HIV infected individuals?
I'm sorry, could you say that one more time?
Sure. Is the SARS-CoV-2 experience people speaking to people living with HIV or non-HIV infected individuals?
Yeah. Well, you know, the studies presented at CROI included both. It included people who had HIV because there was particular interest in seeing whether or not HIV caused people to get COVID-19 more frequently, or whether it caused being HIV positive predicted whether someone would get sicker faster or have more deaths. The studies I showed there, when they compared HIV positive, HIV negative people, they found only in one study that persons who were HIV positive did go into the hospital and did go into the ICU and did go on the ventilator a little more commonly, but they did not die of COVID any more commonly than persons who are HIV negative. So what I can tell you is that it looks like that it's not the HIV that is the biggest factor there. It is the comorbidities, the cardiovascular disease, the kidney disease, the lung disease, especially like emphysema, which really makes the chances of having trouble with COVID more problematic.
Okay, next question. What was the frequency of use for the 211 cohort? I've heard that often it is so frequent it matches daily PrEP of 4 or more times per week.
That's a great question. That's a great question. You know, they've not reported it out as far as I know from the study how often the individuals who were on 211 or intermittent PrEP were taking the medication. I can tell you that that came up as a concern in the study that preceded this one called the IPERGAY study, which was 211 PrEP versus a placebo. And they actually were able to show that not only did high frequency users who were taking an average of somewhere between 4 to 6 tablets per week as intermittent, and that's really pretty much the same as 7 tablets a week when you look at the protection. But they actually looked at people who were taking less than 9 tablets per month. And even in the people who were taking less than 9 tablets per month, the same sort of protection against HIV occurred versus the placebo. We'll have to wait to see the analysis of the Prevnier study to see whether or not they can break out the people who were using the 211 frequently versus those who were using it infrequently. That has not been reported yet, but that's a great question.
Okay, next question. Are there studies going on using implants to administer HIV meds?
Yes, there are. You know, the one I presented there from the Islatrovir, you know, that Islatrovir is probably first of all going to be developed as a prevention against HIV, because what we know from the Victegravir study that I talked about also here, the HPTN 083, is that we can use just one medication to prevent HIV infection. And so that implant that we talked about is able to prevent HIV infection just using one medication, one long-acting, in a slow-releasing form. In order to treat HIV infection, we know we need at least 2. So when we think about an implant, we have to think about, can we get 2 different medications in that implant so that they leave the implant at a slow, constant, and pretty similar rate, so that we actually have, say, a whole regimen, a full anti-HIV treatment regimen in the implant. You know, it could be that one uses the implant, but then takes pills or takes injections along with it. And so it could be that the implant could be used once a year and that the injections could be given once every 2 months. That could be a way that implant plus injections could be used. Of course, it would be optimal or best if we could have just the implant. But so far as I know, there's not been any plans to put 2 medications in the implant, or 2 or 3. But I think that's probably going to be coming down the pike, because even though Islatrovir is going to be for prevention first, it will be used for treatment, I'm sure, soon thereafter.
Okay. We've had a couple of people asking questions about the slides being available. I can tell everyone that this session is being recorded and will be available on the IMAC website tomorrow. You will all receive a follow-up email tomorrow with a link to the recording. So next question. I attended the international workshop on HIV, and the speaker spoke on frailty, since this is a concern for older long-term survivors. It seems this should be a part of talks on HIV and aging. What do you think?
No, I think it should be. You know, I tried to make this presentation reflective of what was presented at the CROI conference. And although I do remember seeing a few abstracts about frailty, it was not one of the major themes to talk about or to kind of report back on from CROI. There was a lot of other treatment, prevention, and a heck of a lot of COVID information. But I agree with you. Frailty is something that has been shown to be more commonly diagnosed in persons who are HIV positive as they increase in age, more so than in persons who are HIV negative when there's been a comparison. And you know what has happened now is that not just the diagnosis of frailty is being addressed, but also some of the treatments, meaning that as soon as frailty is diagnosed, or before it's diagnosed, there are methodologies such as simple to do exercises, simple to do balancing studies, simple to do techniques that will increase the ability of persons to be able to not fall down and hurt themselves. One of the biggest problems with frailty are falls, either out of bed, just falling down to the ground and causing traumatic injury either to bones or to head, the brain. And so finding ways to identify people that risk for frailty and doing something about it is really, in my mind, the most important thing, so that doesn't become another reason that people get hurt or die. But you're right, frailty is going to be a part of, I think, of our lives in HIV from here on out.
And David, I know we are just a little bit over 3, but I have 2 questions. One is more of a clinical question, more of a social question. The first is, so you were mentioning that it is suspected that people who are aging with HIV to develop more comorbidities than their negative peers. And I would like to, for those who don't have the clinical background, if you could expand on why that happens, because one of the things that I've seen is that maybe I think there's not enough research around HIV and aging or interest, and that brings me to the other question: is that if we are already observing a shift in the age of people living with HIV, do you think that the systems of healthcare are ready for what they call in CROI as this silver tsunami?
Yeah, well, I think what's happening is there have been certainly comments about increased number of comorbidities in persons who are HIV positive compared to HIV negative for several years. And by this point, I don't think there is any question that not in all persons who are HIV positive, but in many, when studied in large in increasing in age groups of people, both men and women, it's been found that for any single age, that the proportion of people who are HIV positive having comorbidities is higher than persons who are HIV negative. We think the reason this occurs is that even with treated HIV infection, there is still a low level but persistent level of inflammation, of what's called immune activation, the immune system being turned on and a bit stressed. And that probably has an effect on many organs in the body, the heart, the kidneys, perhaps the liver, and the brain. And therefore, that's the reason we think that these comorbidities are occurring. One of the best ways to try to address this is to make sure that as someone ages, that and their HIV is under good control, that the focus of their health care gravitates away from the HIV a bit and more so onto what's called primary care, on other things besides HIV, on heart disease, kidney disease, brain changes, lung disease. I mean, all of these things are very important. And there are, what's called primary care recommendations for what kind of screening for problematic situations there are. And so, oftentimes what happens is someone is living with HIV for so long, or maybe at least for much of the time they're in healthcare, the focus has always been on the HIV treatment. And at this point, that's the easy part for most people. That's the easy part. One pill once a day, perhaps soon an injection every 2 months is the easy part. What's the more challenging part is really focusing on those comorbidities, doing the preventive screening for them, and doing whatever you can to treat early, treating the high cholesterol and the high lipids early, assessing heart function early, doing preventive maintenance, meaning exercise and changing of diet early. All of this is something that, really I think is important. So as that silver tsunami takes us over in HIV, but also in generalized healthcare, the US population is aging pretty rapidly as well. So this is not unique just to HIV positive persons. It is probably more common in HIV positive persons, but not unique. We need to actually focus on non-HIV parts of healthcare that I think really is what's going to be important, and really move the focus off of HIV onto other very important things.
Great. Thank you for that. Chip, do we have maybe 1 or 2 more questions before we close?
Yeah, we actually have 2 right now.
Okay.
And one is a follow-up on the implants question. That I did not hear well what happens after the 12 weeks of implants.
Oh, well, in the study that was done, the implant was removed. So we really don't know what happened past 12 weeks, because in that initial phase 1/2 type study, the implant was only put in for 12 weeks. And then after 12 weeks, they took it out. You know, that's one of the beauties of an implant is that it can be put in and it can be taken out. So if someone decides they don't want it anymore, unlike an injection, which you can't take out, an implant you can. And so what's going to happen beyond 12 weeks, we don't know for sure, but I'm sure other studies are going to extend that time that someone has an implant well beyond 12 weeks.
Okay, and the last question we currently have. Historically, women have not been included in many studies, resulting in very different side effects. Is that protocol going to be changed moving forward?
Yeah, you know, I think one of the studies we talked about today, one of the long-term cohort studies called the WIHS, WIHS, which is now part of a larger study called the Combined Cohort Study, has been addressing questions of HIV in women very directly, because it's an all-women study. It compares HIV positive women to HIV negative women. It's been going on since about 1994, so it has some pretty long duration. I agree with you that there has been an underrepresentation of women, particularly in clinical trials. You know, and the reason for that is oftentimes is that what has been discussed many times is that you're right. We don't know as much about how women, take, tolerate, do with how well they do with HIV medications, because there haven't been enough women in many clinical trials. There have been some. There's been probably about 3 or 4 all-women clinical trials, which have been really good to give us some insight. Most of those clinical trials are showing very similar response rates, very similar T-cell rebuilding rates as the trials that contain primarily men. So we're not seeing huge differences. We sometimes see different side effects or different proportion of side effects, like more gastrointestinal. But by and large, the all-women studies are not showing us too much difference than than primary men studies. The thing that is different is that there's usually a higher discontinuation from study rates in the women's study, and that's probably because that many women who are in the studies have other priorities in their life, such as family, such as children, such as taking care of more than just themselves, and that makes it oftentimes difficult to dedicate a lot of time to a study. So, that's one of the biggest problems, in my opinion, of what we have to address is support to keep women in studies.
Awesome. I want to thank you, David, for always being available for us. This was really enlightening, so thank you very much. And I hope this information is useful to people and that they can incorporate it into their work. And I think that the huge takeaway, kind of tying into what you were mentioning, is to advocate for those groups that are not necessarily represented on clinical trials, like women, people with trans experience, and also to expand research on HIV and aging. So again, thank you very much, David, and we will see you all soon. Thank you all for joining. And remember to please evaluate the session.
Thank you, Damien. Thank you all for your attention.
Thank you. Ciao.
Ciao.